Thank you to Dr. Weidman for the introduction, and I wanted to thank the organizers from the CCF for giving me the opportunity to present and discuss my research today. So I'll be talking about disparities between bone marrow B-cell aplasia and minimal residual disease in pediatric and AOA B-ALL after CAR T therapy. So as we've already learned today, B-ALL is the most common childhood cancer, making up about 25% of cancer diagnoses amongst children less than 15 years of age, with a 5-year survival rate of about 90%. But for relapse disease, that unfortunately does decrease by quite a bit. It is about 50%. As we can see in the curve on the right, the green line is representing relapsed B-ALL with a survival rate of about 50%. As we've also previously discussed today, CAR T-cell therapy has transformed our approach to relapsed and refractory B-ALL, in which a patient undergoes a process called apheresis, in which their T-cells are taken out of their body and then modified to express a specific antigen expressed on their leukemia cells, most commonly CD19, and then those cells are then given back to the patient in order to fight their leukemia. Kymriah is the approved product for children with B-ALL, but there are other products that Dr. Silbert referred to in her talk that will also be relevant to this talk. We do need a way to test how we are doing treating a patient's leukemia and how much leukemia is still in their blood or their bone marrow, and that's when minimal residual disease comes in, which is the threshold that is used to identify any residual leukemia cells. This is typically measured throughout multiple points in a patient's treatment, specifically after the first stage of treatment, which is induction, and then if a patient has residual leukemia after induction, then this is measured in the following stages of their treatment plan. Patients, as you can see on the curve to the right, typically do better and have better outcomes if they're MRD negative after induction therapy, and then thereafter if they're also MRD negative after consolidation therapy. This is typically measured by flow cytometry, but we'll get into some other ways this can be measured, and 0.01 is the threshold to consider someone MRD negative or MRD positive. Flow cytometry is the typical technique in which minimal residual disease is assessed, and this is where we're able to detect in a sample of blood or bone marrow the percentage of residual leukemia cells by looking at cells that express specific markers or antigens that are present in their leukemia cells. This is typically less sensitive than our other method we'll discuss. For every 10,000 cells, you're able to detect down to about 1 leukemia cell in that sample. It's less expensive and it's typically run in-house as opposed to sending it out to a lab elsewhere, and this has a faster turnaround time. Next generation sequencing is a technique and where we're able to look at specific DNA changes in a patient's leukemia and then track those changes over time. This is more sensitive. For every 1,000,000 cells, we're able to detect down to 1 leukemia cell. This is more expensive though and does have a longer turnaround time, as there is a company called Adaptive who runs the specific test called clonoSEQ, and these samples are sent out to be run there. And then B-cell aplasia is what refers to lower absent B-cell counts after CD19 or other therapy that attacks a patient's B-cells. And so we have these effects that are on tumor but off target, and so we are depleting patients' normal B-cells in addition to their leukemia cells. This is typically measured in the peripheral blood, and it's used as a surrogate marker for CAR T persistence. In the curve on the right, you can see that patients who lose B-cell aplasia or recover their B cells have inferior outcomes, especially within 1 year post-CAR T therapy. And then finally, some background information on extramedullary disease. The typical sites for this are testicular and CNS disease, and this is leukemia outside of the bone marrow. And often in patients with relapsed and refractory disease, we do see other sites of extramedullary disease in addition to testicular and CNS disease, and we look at this with PET scans, which you can see on the right. So the objectives for my research project were to cross-compare biomarkers of disease assessment pre- and post-CAR T-cell therapy in patients who have achieved an MRD negative complete remission at day plus 28. We looked at some markers pre-CAR T therapy and then also post-CAR T therapy. Pre-CAR T therapy, we looked at peripheral blood B-cell aplasia, which was measured by flow cytometry, and then post-CAR T cell therapy, we looked at peripheral blood B-cell aplasia, we looked at flow cytometry B-cell aplasia in the bone marrow, NGS MRD in the bone marrow, and then NGS B-cell aplasia in the bone marrow. What's novel about this analysis is that typically when people are measuring B-cell aplasia, they're looking in the peripheral blood, not in the bone marrow, and using flow cytometry if they do look at this in the bone marrow and not using next-generation sequencing, which is more sensitive. We wanted to evaluate these above biomarkers for predictability of relapse, and our significance is to understand how all of these different biomarkers relate to one another at critical time points post-CAR T therapy to see if we can predict those who are at risk of relapse or identify early relapse to give other treatments. This was a retrospective study of patients who received investigational CAR T cell therapy at the NCI from 2018 until 2024. Patients who had clonoSEQ reports available were assessed for NGS MRD status and NGS BCA at day plus 28 post-CAR T therapy, which is our typical first time point for restaging post-therapy. We were able to look at the clonoSEQ reports, and with the below equation, we were able to look at the percentage of B cells in the bone marrow, and we defined B-cell aplasia as less than 1% of B cells. This definition is not yet standardized, and so may change over time as we move further along in this project, but this is what we used for this analysis. All included patients in this analysis were in a flow cytometry MRD negative remission at day plus 28, and then patients who had extramedullary disease either had a complete or partial response. We excluded patients who either had stable disease or progressive disease of their extramedullary disease. We started off with 169 eligible patients who received either CD19, CD22, or bivalent CD19-22 CAR T cells. We excluded patients with lymphoma, and then we're left with 163 patients who had a diagnosis of ALL. And then we excluded patients with an adequate response, as we discussed, patients who had MRD level disease by flow cytometry or patients who did not have response of their extramedullary disease, which left us with 91 patients in a complete remission at day plus 28. And then we did not have NGS data available for 68 patients, and so we were left with a cohort of 23 patients who we had that data available for. Our patient characteristics, we had 26% of patients who were treated with CD22 CAR and 74% of patients who were treated with bivalent CD19-22 CAR. 26% of our patients had extramedullary disease and 52% were female, 48% were male. The median age was 13 years with a range of 4 to 38. This is a heat map of our data. I know this is a lot of data, but we'll break it down in the next couple of slides. But I wanted to point your attention to the post-CAR flow cytometry BCA and NGS BCA columns. These were both done in the bone marrow, and we did find that these two methods of looking at B-cell aplasia were quite concordant with one another, with only a few patients who had B-cell aplasia by NGS not having B-cell aplasia by flow cytometry. And then I also wanted to point you to the column on the right where we're looking at NGS MRD. And so all of our patients were in a flow cytometry MRD negative remission at day plus 28, but there were quite a few patients who did have disease by NGS and quite a few patients who had quantifiable disease, which is the dark blue. And then also wanted to point out that some of these patients who did have quantifiable disease by NGS still had B-cell aplasia at this time point, which is often the marker we're using to look at persistence of CAR T cells and risk of relapse. So we did find that flow cytometry BCA was overall concordant with NGS BCA. 77% of patients had flow cytometry BCA at day plus 28, and 87% of patients had NGS BCA at that same time point, which you can see on the pie charts on the right. There were 2 patients who had NGS B-cell aplasia but did not have flow cytometry B-cell aplasia. Looking at NGS MRD versus NGS BCA, 52% of patients were NGS MRD positive at day plus 28 post-CAR. And again, these are patients who are all MRD negative by flow cytometry. And 83% of those patients also had B-cell aplasia by NGS. In contrast, 48% of patients were NGS MRD negative at day plus 28 post-CAR, and 91% of those patients had NGS BCA. So no matter the MRD status of our patients, most of them did have B-cell aplasia, with slightly more having B-cell aplasia in the MRD negative group. Out of our 23 patients, 11 of them, or 48% of them, did eventually relapse. As you can see in the bottom patient, there were 5 patients who were NGS MRD positive and had NGS B-cell aplasia at day plus 28, and those are of patients who relapsed. And then to the right in the orange is NGS MRD negative patients who also had B-cell aplasia. 4 out of 11 patients relapsed. And then 1 patient who had NGS MRD positive disease without B-cell aplasia, and 1 who had NGS MRD negative disease without B-cell aplasia relapsed. So on the right, this is the same data that's broken down at percentages. So about 45% of patients who had both NGS B-cell aplasia and were MRD positive ended up relapsing. About 35% of patients who only had NGS B-cell aplasia ended up relapsing, and 10% each for patients who had neither B-cell aplasia or NGS MRD positive disease relapsed, and same goes for patients who were only NGS MRD positive but did not have B-cell aplasia. We did find that MRD positivity at day plus 28 was a significant factor in time to relapse. 44% of patients with both NGS MRD negativity and NGS BCA at day plus 28 relapsed, and none of these patients had pre-CAR peripheral blood B-cell aplasia, which was the main factor that was similar amongst those 4 patients who relapsed but did have NGS MRD negativity and B-cell aplasia. 3 of 4 of those patients had extramedullary disease. About half of those patients did have significant bone marrow disease pre-CAR, and half of them did not. We did find the median time to relapse was about 5.2 months in those who did have NGS MRD positive disease at day plus 28 versus 11.7 months in those who were NGS MRD negative at day plus 28, which you can see in the graph to the right. We did also find that extramedullary disease was a strong predictor of relapse. 26% of patients, as mentioned before, in our cohort did have extramedullary disease, and all 6 of those patients went on to relapse. And that does include 4 patients who were NGS MRD negative at day plus 28. So some of our conclusions, we did find that most patients with flow cytometry MRD negativity achieved both marrow NGS BCA and flow cytometry BCA. We did find that neither NGS BCA or flow cytometry BCA were fully concordant with NGS MRD at day plus 28. And we did find that the majority of patients who relapsed post-CAR-T infusion did have NGS MRD positivity on day plus 28 or a history of extramedullary disease, regardless of their B-cell aplasia status at day plus 28 by either method. We do have some future directions of this project. We are expanding our cohort to include patients who received commercial CD19 CAR-T therapy in a collaboration with Johns Hopkins. So we're able to have patients who were treated with standard of care as opposed to being treated on research studies. And then as our patients who did receive investigational CAR T-cell therapies, we're also expanding our cohort to include patients who were treated on the bicistronic CD19-22 trial. And then we also are able to look at additional NGS reports at different time points post-CAR to assess that relationship on relapse status. I did want to thank the whole LLTCT team, especially my mentor, Dr. Nurali Shah. I also wanted to thank Dr. Julie Ma, who's one of the immunotherapy fellows who helped me analyze this data and also reviewed my slides for this presentation. I wanted to thank Dr. Charles Bonifant, who is collaborating with us from Johns Hopkins to include additional data for our project. And then from Adaptive Biotechnologies, I wanted to thank Dr. Lanny Kirsch, who was able to review the NGS reports with us and help us analyze B-cell aplasia data with those reports. Are there any questions?
Hey, so I was wondering if you ended up doing any assessment of sensitivity or specificity analysis on MRD versus BCA to relapse, predicting relapse?
Sorry, I just want to confirm the question. So, looking at like each metric,
Right. So it's how sensitive and how specific is, let's say, NGS BCA versus NGS MRD compared to the traditional flow analysis?
I know NGS MRD has a sensitivity about 1 times 10 to the 6th. We did discuss with the adaptive team the sensitivity of measuring B-cell aplasia by NGS. I'm not sure if they're able to tell like an exact sensitivity of it, but long term in the project, we'll kind of look at those factors independently on how they predict the risk of relapse.
So these are patients who are getting reinfused with a product, and you've now got an assay that will detect, as you say, 1 in a million. Did anybody look at the reinfused product to see if any leukemia cells were getting reinfused into the patient with their various CAR T because of either expansion or just to look and see if you just by chance were reinfusing any leukemia cells along with your product?
Not to my knowledge. All of these patients were also a first infusion and have not been reinfused with CAR T cells. Some of the patients who we included as separate patients received a completely new CAR T construct and not a reinfusion. But I'm not sure if that's answering your question. I apologize. Mm. Mm. That's not something we looked at, but could look at it in the future potentially.